Good evening, sir. My topic is delirium. Starting with definition, the American Psychiatric Association defines delirium as the disturbance of consciousness, attention, cognition, and perception, which it develops over short period of time. According to DSM-5, there is some diagnostic criteria. It has 5 points. The first is disturbance in alertness and attention. The disturbance develops acutely and is tends to fluctuate in severity. At least one additional disturbance in cognition, example, orientation, memory, perception, or language. And that cognitive disturbances can't be better explained by pre-existing or establishing neurocognitive conditions, example, dementia, or be present in severely reduced arousal state such as coma. And the evidence of any underlying organic causes, any exposure to any toxin or any substance withdrawal. Okay, sir. That's and incidence and duration of delirium. And delirium occurs over average incidence rate of 28% during ICU stay. The duration of delirium varies strongly between patients with a median duration rate 2 to 3 days. And the risk factors we can classify as predisposing risk factors and precipitating risk factors. Predisposing risk factors that they are the pre-existing factors that increase patient vulnerability to delirium. Where the precipitating risk factors, the factors that trigger the onset of delirium. Some established predisposing risk factors at the old age, cognitive impairment, pre-existing hypertension, nicotine or alcohol use. The precipitating factors that acute illness related disorders like previous coma, any trauma, sepsis, pain, metabolic acidosis, or some medication related factors like benzodiazepine, usually increased risk in the dose dependent manner. Some anticholinergic drugs, steroids may cause delirium, and some environmental factors like increased noise or lack of daylight. And these both predisposing and precipitating factor can interact with each other. More or stronger the predisposing factor present, weaker or few precipitating factor are required to develop delirium. And the old age patient with cognitive impairment can develop delirium with one mild hypoxia, whereas a young patient, young fit guy who developed delirium in case of any major trauma or sepsis. And it's a pathophysiology. There's a various neurotransmitters are involved in the process. There's an increased level of dopamine and a decreased level of acetylcholine are thought to increase neuronal excitability and precipitate delirium. And it's a tryptophan, which is a precursor of serotonin and subsequently melatonin production. Low levels of serotonin, melatonin can cause delirium. And the phenylalanine actively transported across blood-brain barrier. We are the same transporter as tryptophan. So the increased concentration of phenylalanine can reduce the concentration of tryptophan, and again it can cause delirium. And some inflammatory response to critical illness causes the release of cytokines into the circulation, which also result in prothrombotic state and thus lead to reduced cerebral blood flow, can trigger delirium. It's a clinical presentation. It has usually acute onset, occurs with few hours or days after the onset of underlying disease. Features is usually there's changes in conscious level, attention, and sleeplessness, and disorientation to time and place. According to psychomotor alterations, delirium separated into hyperactive, hyperactive, and mixed type. Where the hyperactive type is a reduced alertness, is usually misdiagnosed as a depression, and the hyperactive type is a restlessness, increased motor activity, and agitation, is most commonly caused by drug withdrawal. And there's also perception disturbances also present in delirium, but in less cases. The severity and symptoms of delirium may fluctuate during the day, typically with restlessness in the evening and at night, that is sundowning, and daytime sleepiness. So management, first diagnosis. Several tools have been developed to improve the detection of delirium, of which confusion assessment method for the ICU. So CAM ICU method is the most commonly used, and also there is an intensive care delirium screening. CAM ICU is a brief assessment based on formal testing, while intensive care delirium screening is based on observation during night shift, nursing shift. Key features of delirium is inattention, which can be easily assessed using attention screening examination test, that is a part of CAM ICU testing. In assessing the patients of delirium, it is important to look for symptoms and signs of delirium mimics and for specific causes of delirium that may require specific treatment. Caution is needed in patients with focal neurological signs as atypical presentation, example psychosis in patient with normal attention and consciousness, and atypical onset, either way acute or chronic. And in typical cases, diagnosis can be made without imaging or neurophysiological test. CT or MRI needed in patient who showed new focal signs or other features that are uncommon in delirium and that suggest structural causes. ECG changes during delirium include the diffuse slowing of background activity. And it's a prediction. There are several models available. There's a early prediction of delirium ICU, which is commonly used. It contains 9 predictive factors. And the second model is pre-deliric phase, which is more feasible. And the treatment is a non-pharmacological and a pharmacological, both methods are there. It's a non-pharmacological prevention. As a multifactorial approach instead of single intervention seems to be appropriate. This may include early mobilization, use of earplugs, reduction of nighttime light, noise, and increased exposure to daylight, and reorientation program with cognitive training. Another multi-intervention approach is the use of awakening and breathing coordination, delirium management, and early exercise, mobility, family engagement bundle, which are significantly associated with a decreased incidence of delirium and reduced hospital mortality. And the pharmacological preventions, we have to avoid some predisposing drugs. As benzodiazepines seem to be particularly associated with the development of delirium in the critically ill patients. The delirium increases by 4% with every 5 milligram equivalent dose of midazolam. And also, there's another one thing is a pain. Severe pain is present risk factor for delirium. Adequate pain management is also important. Non-opioid anesthesia may be provided. And there's a pharmacological treatment. And haloperidol is the most commonly prescribed for the treatment of delirium. And the Society of Critical Care Medicine guidelines recommend that there's a haloperidol should be restricted to treatment of ICU delirium with agitation and psychosis. And atypical antipsychotics can be used, but it has fewer adverse effects than the typical antipsychotics, but it can't be administered intravenously. So in case of acute psychosis, haloperidol, we can give it haloperidol because it has a rapid action, and we can give IV administration, 0.5 to 5 mg repeated 3 times depending on age. And in case of agitation, the first step in the management of agitated patient is to evaluate and treat the underlying causes such as pain, itching, constipation, or any bladder retention. Further reassurance and implementation of non-pharmacological measures such as relaxing music, anything are warranted. And we can use dexmet and chloride that may be superior to haloperidol in case of agitation. And in case of anxiety, delirium may be associated with anxiety that does not respond sufficiently to non-pharmacological measures such as reassurance and music. So we can give here also, we can give the alpha-2 agonist to reduce the anxiety instead of benzodiazepines. And in case of hyperergenic state, is present with hypertension, tachycardia, spontaneous hyperventilation, and sweating. Here also we can give that alpha-2 agonist and anticonvulsant drugs. It's mostly due to that drug withdrawal. Okay, sir. Thank you, sir.
In your short experience in this department of anesthesia, have you seen a case of delirium? What was the patient? Why? Which patient had delirium? Is it a post-operative patient or a patient admitted with a metabolic problem in the ICU?
It's a metabolic problem in the ICU, sir. It's a polytrauma. It's a 22-year-old male, sir. Who was chest injury and it's a femur fracture, sir.
Okay.
Who presented with a delirium? It's a CT brain and everything is normal.
So
Yes,
when a
sir,
long bone fracture is there, what is the cause of delirium?
Probably due to
Abhirami? Can you tell me the cause of delirium in a young patient with a long bone fracture on the second or third day? Soundarya?
Any fat
Fat embolism, yes. That is one of the commonest causes for delirium or confusion. Okay? Maybe not very violent form or the so-called hyperactive type,
yes,
but usually it starts with confusion, then patient goes into hypoxia. There may be dermatological changes like petechial hemorrhages. Okay, so this is a very common scenario that you will come across as you go into your practice later on in your life also. But the commonest people who become delirious, who are likely to have delirium, which age group is that?
Old age,
elderly people, sir.
Elderly.
Elderly age group patients. Why do they have this problem? Supposing you get a case of
Elderly
fractured neck of femur in an 85-year-old patient. He is brought to the hospital after 24 to 48 hours. What are all the reasons for this patient to become delirious?
Dementia.
Dementia, which may be already existing. We don't call that as a delirium. Dementia is a disease which is already there. Delirium is a transitional or a sudden change in the level of consciousness as we first described that. So in an elderly patient with a fracture, is it going to be painful?
Yes, sir.
Yes, sir.
Very painful, isn't it? Yeah? So for the pain, they don't know how to react. They may initially shout and cry and verbally say that they are having pain, but once the pain becomes intolerable, they become delirious. What are the other reasons for an elderly person with a fractured neck of femur to develop a delirium other than the pain?
metabolic derangements.
Acidosis.
What metabolic derangement?
Hyponatremia.
Hyponatremia.
Electrolyte imbalance.
Imbalance.
They normally don't drink enough water. They become dehydrated and they develop electrolyte imbalance. And elderly people, do they require some sensory adjuncts or equipments for their vision and hearing? What are all the common adjuncts they use for the sensory aspect of their life?
Hearing aids, sir.
Hearing aids, glasses.
Glasses.
Okay? So if you prevent them from having that, can that produce delirium?
Yes, sir. Yes, sir.
Yes. One of the important causes that have been found out that post-operatively a person who has been used to having a hearing aid or a glasses, if you don't provide them in the post-operative phase, that it may cause the delirium. And other rare cause for delirium, early onset of infection. Where are all the sites where the patient can develop infection which can manifest as delirium? What are all the common infections, especially in an elderly patient?
UTI.
UTI, very good. Then is other source of infection. You don't mobilize them early. You make them lie down. That's the clue I'm giving you.
Bed sores.
Bed sores,
Huh?
sir. Bed sores.
Bed sore is not that's a superficial infection. An occult infection which you have to think of and detect early.
Lung
One is
infection.
UTI. Lung infection, basal atelectasis and pneumonia. That is the second important infection, especially in the elderly who are not mobilized or given physiotherapy at the earliest, the post-operative period. These two infections are the very important causes for delirium in the elderly: urinary tract infection and pneumonic infections in the lung. Okay? And any withdrawal symptoms. What are all the, supposing a patient is an alcoholic. Have you ever seen a severe alcoholic who has sustained a trauma coming to the hospital, getting operated? What will happen to them in the second or third post-operative day when he is not able to drink? What are all the features of alcohol withdrawal?
It's a delirium.
Yes.
Starting from confusion, delirium, and tremors,
Anxiety,
tremors,
tremors.
and finally seizures, sir.
Seizure. Before that, he will have a lot of sweating, tachycardia, hypertension, all sympathetic stimulation because the withdrawal produces a start of stress response. Okay, so the patient develops hypertension, tachycardia, diaphoresis, then he becomes initially confused, then he becomes delirious, then he becomes violent. Okay, so how do you treat withdrawal from alcohol? What is the method of treating alcohol withdrawal? Will it be uh, corrected or treated with your simple allopurinol and other drugs?
We'll give naltrexone, sir.
Naltrexone. Why naltrexone?
It is a supportive treatment of withdrawal in terms of alcohol, sir.
Thiamine.
Thiamine should be
Actually,
given.
thiamine is one of the deficiencies that may trigger that. But actually, they say the ideal treatment is to give titrated quantities of alcohol, ethanol to them. Okay? That is the first treatment that you have to start with. Then only there will be some. We have had a few cases like that in our career earlier, where you give them 1 or 2 pegs of ethanol, then they quieten. Then you go to take them to the counselor, give them a lot of psychiatric counseling, and then gradually make them understand that this habit is causing all this problem, and then you try to rectify them from that. So, do you recommend giving 30 to 60 ml of ethanol for these patients to quieten down, along with all other supportive treatment? So, like that, all these things are causes of delirium. Why you want to control this delirium? You described all the things about delirium nicely, but why you are worried about this delirium? What is the prognosis of the patient who develops a delirium? Morbidity and mortality is very high if you don't control delirium. Okay? And they continue to go and have post-traumatic stress disorder also if you don't control the delirium. Okay? And of course, restraining the patient. You would have seen the nurses tying the hands and legs and tying
Yes, sir.
it to the railings of the cot. Is it a good thing to do?
No, sir.
The patient is violent, if he is
Yes,
hyperactive.
sir.
Is it correct to restrain a patient like that?
No, sir.
As far as possible, no. Okay, but as they pull out the lines, if they try to knock out the IV stand, if they try to bite and harm the medical personnel or paramedical people attending, then there is no other go except to restrain these patients. But as far as possible, you should identify the cause and then try to rectify that as early as possible so that delirium can be controlled. Okay, so
Yes,
unless
sir.
you pinpoint the causes and treat it, delirium will cause more harm to the patient because it is one of the indicators of morbidity and mortality. Okay, so you must be able to identify who are all the potential candidates who can develop delirium before admission to ICU or in the post-anesthetic or post-operative area, and take care of all the prevention is better than cure. So always try to make sure that they are adequately hydrated, the pain relief is good, and if they have been taking any medications, don't withdraw that, continue that. For example, some elderly patients are constantly in the habit of taking diazepam at night. Without that, they may not get sleep, or they
Yes,
may
sir.
develop a psychological feeling that without that one tablet of Alprax or Restil, they will never get a sleep. That sort of psychological feeling they will have. So at least you give a placebo and then tell him that this is the Alprax tablet and try to pacify them. So it is a multimodal mode of treatment. And as you said, the pathophysiology, nobody knows why it happens. Majority of the things are only theories or postulations why it is happening. And the two theories are, one is, actually three theories. One is inflammatory theory, the second is the neurotransmitter theory, and the third is the ischemic theory. These are the three theories or postulations that are described as causes for that. So you have to, this question comes in your theory paper, you have to first say definition of delirium, then second is signs and symptoms of delirium, 3 causes of delirium, 4 pathophysiology of delirium, 5 identification or risk stratification for delirium, 6 is to management of delirium. So
Yes.
under these headings, you can classify your answer and then present it so that it will be a uniform and nice presentation. Okay?
Yes, sir. Yes, sir.
So I'll try to share my slides for you to have a visual effect on this presentation.